Welcome to our video on hypertensive crisis. Let's begin. In this lecture, we'll cover hypertensive urgency and hypertensive emergency. Since these two pathologies are so similar, we'll cover them simultaneously, making sure to highlight the key differences where appropriate. Specifically, we'll go over the definition, etiology, clinical features, diagnosis, and management of both hypertensive emergency and hypertensive urgency. Let's begin with the definition. In the general population, hypertensive urgency is defined as a blood pressure greater than or equal to 180/120 without any evidence of end organ damage. Hypertensive emergency, on the other hand, is defined as blood pressure greater than or equal to 180/120 with evidence of end organ damage. When it comes to the etiologies of hypertensive crisis, there are many. This slide includes the most common etiologies of hypertensive crisis, but it is by no means meant to be exhaustive. The key here is to be familiar with these associations, not memorize every possible etiology or severely elevated blood pressures. With that in mind, let's go through these one by one. Noncompliance with antihypertensive should be intuitive, and noncompliance with dialysis leads to hypertension due to volume overload. Drugs with sympathomimetic effects, such as methamphetamines or cocaine, exacerbate hypertension by stimulating systemic vasoconstriction. Alcohol withdrawal leads to hypertension because alcohol depresses the nervous system. Hence, abrupt cessation of alcohol can result in overactivation and dysregulation of the nervous system, which may result in severe hypertension and other forms of hemodynamic instability. Hyperaldosteronism, for example, due to an adrenal adenoma, leads to hypertension because aldosterone works by retaining water in the blood vessels, thereby leading to higher blood pressure. Renal artery stenosis, which may occur due to fibromuscular dysplasia or atherosclerosis of the renal arteries, leads to hypertension by activating the renin-angiotensin-aldosterone system, which increases the production of aldosterone and hence retention of water. Similar to renal artery stenosis, pielocystic kidney disease also leads to hypertension by activating the renin-angiotensin-aldosterone system. Lastly, pheochromocytoma leads to hypertension by releasing large amounts of catecholamines such as epinephrine and norepinephrine into the bloodstream. These catecholamines in turn stimulate systemic vasoconstriction and lead to elevated blood pressure. When it comes to the clinical features of hypertensive crisis, hypertensive urgency is largely asymptomatic. Hypertensive emergency, on the other hand, may present with signs of end organ damage, posterior reversible encephalopathy syndrome, also known as PRES, and malignant hypertension. Let's go through each of these manifestations one by one. The most common signs of end organ damage associated with hypertensive emergency are listed on this slide. These include hypertensive encephalopathy, which usually manifests as headache, nausea, and nonspecific neurologic signs like confusion, stroke, intracranial hemorrhage, papilledema, aortic dissection, heart failure, acute coronary syndrome, such as myocardial infarction, pulmonary edema, acute kidney injury, renal failure, and oliguria. High blood pressure can essentially affect any organ in the body, which is why it is so important to be aware of these manifestations in order to properly evaluate a patient presenting with a very high blood pressure. Posterior reversible encephalopathy, or PRES, is basically encephalopathy caused by uncontrolled severe hypertension. The most common clinical features include headache, visual disturbances, seizures, and altered mental status. Despite the name of this condition, these clinical features may not always be reversible, especially if this disorder is not recognized upon initial presentation. The diagnosis is suggested by clinical features and is confirmed with MRI of the brain, which typically reveals signs of edema in the parieto-occipital lobes. Here's a brain MRI taken from a patient with posterior reversible encephalopathy syndrome. Note these areas of hyperintensities in the patient's occipital lobes as well as parietal lobes. They are caused by vasogenic edema, which occurs as a result of severe uncontrolled hypertension. Notably, this disorder has the word posterior in its name because of the frequent involvement of the occipital lobes, which make up the posterior aspect of the brain. Malignant hypertension is a subtype of hypertensive emergency that is characterized by a rapid rising blood pressure in the context of papilledema, retinal hemorrhages, and/or exudates on fundoscopic exam. Importantly, this disorder is associated with malignant nephrosclerosis, which usually presents as renal failure, hematuria, and proteinuria. This disorder may also cause rupture of arterioles within the kidneys, yielding the so-called flea-bitten kidney appearance on pathologic examination. Here are two images obtained during a fundoscopic exam of two different patients. The image on the left was taken from a healthy patient, whereas the image on the right was taken from a patient with papilledema. Note this small white circle within a larger white halo on the left image, which represents the optic cup and the optic disc of the optic nerve, respectively. Notice how the optic cup is smaller than the optic disc and how both of them have very clearly delineated circular shapes. Now consider the image on the right. This right here is where we're supposed to see the optic cup and optic disc. However, in patients with papilledema, the optic nerve becomes swollen due to elevated intracranial pressure, which makes the optic cup and disc appear blurry and distorted. Hence, a blurry and distorted optic nerve on fundoscopic exam is consistent with the diagnosis of papilledema and would be considered a sign of end organ damage in patients with severely elevated blood pressure. Here's an image showing the gross appearance of a so-called flea-bitten kidney. Note these small hemorrhages throughout the cortex of this kidney, making it seem like this kidney was bitten by a bunch of fleas. As mentioned on a previous slide, these hemorrhages may occur as a result of malignant hypertension, leading to rupture of small renal arterioles. What is the key difference between hypertensive urgency and hypertensive emergency? The key difference between hypertensive urgency and emergency is the presence of end organ damage. Hypertensive urgency will not have any associated end organ damage, whereas hypertensive emergency will have signs of end organ damage. Remembering this difference has important implications in the diagnosis and management of these two conditions. The diagnosis of hypertensive crisis begins with a blood pressure measurement, followed shortly by a careful assessment for signs of end organ damage. At minimum, patients suspected of having a hypertensive crisis should be evaluated with a CBC with peripheral smear, a CMP, a urinalysis with microscopy, an ECG, and chest X-ray. Clinicians should also consider ordering a non-contrast CT head for patients with neurologic symptoms, such as a headache or altered mental status. Following the thorough diagnostic assessment, if the patient is determined to have hypertensive urgency, clinicians should lower the blood pressure using oral antihypertensives gradually over a period of 24 to 48 hours. Commonly used medication options include oral labetalol, nifedipine, and captopril. If the diagnostic assessment reveals signs of end organ damage, however, the patient is determined to have hypertensive emergency, which warrants admission to the ICU. Once in the ICU, clinicians should lower the blood pressure using intravenous medications rather than oral medications. The key to management of hypertensive emergency is to remember the goal blood pressure reduction rate. Clinicians should reduce the mean arterial pressure by 10 to 20% in the first hour and 5 to 15% in the next 23 hours. This slow, gradual reduction in blood pressure is meant to allow the body's autoregulatory mechanisms to maintain appropriate cerebral perfusion while the mean arterial pressure is being lowered. If clinicians were to suddenly drop a patient from a systolic blood pressure of 200 to a systolic blood pressure of 120, for example, it may lead to a sudden impairment of cerebral perfusion and potentially permanent ischemic damage like a stroke. Commonly used medication options for hypertensive emergency include intravenous labetalol, nicardipine, usmle, nitroprusside, and hydralazine. Finally, clinicians may consider transitioning patients to oral antihypertensives after the first 24 hours of therapy. A 52-year-old woman with a past medical history of diabetes and hypertension presents to the clinic for a yearly checkup. She has a blood pressure of 180/120. Her blood pressure used to be well controlled with captopril, but she's forgotten to take her medications for the last 5 days while being on vacation. She has no complaints. The physical exam is unremarkable. What is the best next step in managing this patient? This patient presented with a blood pressure of 180/120 and has a past medical history of hypertension. Based on these findings, she is most likely experiencing a hypertensive crisis. She has no complaints and the physical exam is unremarkable. So the type of hypertensive crisis she is experiencing is likely hypertensive urgency, as hypertensive emergency would present with signs of end organ damage. Her blood pressure used to be well controlled with captopril, but she has forgotten to take her medication for the last 5 days. Therefore, we can reinstitute her captopril regimen. The best next step in the management of the patient with hypertensive urgency is to reinstitute or increase the dosage of oral antihypertensive therapy. A 75-year-old man is brought to the emergency department due to severe headache and nausea that started 3 hours ago. He also complains of severe blurred vision. His past medical history includes poorly controlled hypertension and second-degree atrioventricular block, type 1 from previous Lyme disease. His vital signs include a blood pressure of 200/130, heart rate of 63, and respiratory rate of 15. Fundoscopy displays swollen optic discs with blurred margins. Non-contrast head CT scan is unremarkable. Which of the following is the best treatment option for this patient? A. IV nitroprusside. B. Sublingual nitroglycerin. C. Oral verapamil. D. Oral metoprolol. This elderly man with poorly controlled hypertension reports severe headache, nausea, and blurred vision. Fundoscopy displays swollen optic discs with blurred margins, suggesting papilledema from increased intracranial pressure. His vital signs are remarkable for a blood pressure of 200/130. A blood pressure more than 180/120, with signs of end organ damage such as papilledema, is consistent with hypertensive emergency. Intravenous medications are typically used for the initial management of hypertensive emergency. Commonly used medications include IV nitroprusside, labetalol, nicardipine, usmle, clevidipine, hydralazine, and phenoldiprem. Nitroprusside is the only IV medication listed as an option in this question. It works by dilating the blood vessels and reducing afterload. Therefore, the correct answer is option A. This is the slide reminding us of the management options for hypertensive emergency. Let's discuss why other options are incorrect. Option B, sublingual nitroglycerin, is incorrect because it is typically used to treat angina rather than hypertensive emergency. Option C and D are incorrect because verapamil and metoprolol work mostly on the myocardium rather than the blood vessels. Therefore, they are not the first-line medications for the patient with hypertensive emergency. Additionally, these two medications can exacerbate the patient's atrioventricular block by further slowing down the AV node. And that concludes our lecture on hypertensive crisis.